Our next discussion is titled Successful Housing, Successful Aging. Please welcome moderator Jennifer Ho, Senior Advisor for Housing and Services, U.S. Department of Housing and Urban Development.
I love the after lunch spot. Especially today, because I think it's required that you be super energetic when you moderate the after lunch spot. But this is a topic that is very, very easy for me to get energized by. It says in your program that we're talking about the aging of the baby boom. But my new boss, Secretary Castro, and I are Gen Xers. But we're aging too, and are very aware that successful aging for the baby boom is going to have everything to do with successful aging in our own lives as well. So he talked today about the fantastic need for HUD-assisted housing, for more affordable housing options, and for an understanding of housing in this bigger context. Today, we're going to look specifically at that need as it relates to seniors, and I'm delighted to have with me a very distinguished panel of guests. So let me welcome to the stage first Jennifer Malinsky. She's a research associate at the Joint Center for Housing Studies at Harvard University. And if you have not read her report, I want you to know I've read it twice. So it is fabulous. It's great to be here with Jennifer today. We've got Mike Erickson, who's an assistant professor at the Department of Finance, of all things, at Texas Tech University, who's going to help us think about the cost effectiveness of what we do in housing. And we've got Pam Parsons, who's with us today. She's the Director of Practice and Community Engagement and Associate Professor at the School of Nursing at Virginia Commonwealth University. And I understand Pam gets things done on the ground. Pam, great to have you here today. And James Taves. James and I have the pleasure of working together in the HUD-HHS collaborative relationship. And James is just a wealth of knowledge from his work in states, but also the work that he's doing on federal policy. So he's going to bat federal policy wrap up. I just want you to know before we start that at HUD, at HHS, we are thinking together a lot about the relationship between housing and services and the impact of housing on health and healthcare. And I'm very, very honored to be able to moderate this panel today. But enough about me. Jen, why don't you come up and walk us through your fabulous report?
Thank you. So thank you, Jennifer, and it's a pleasure to be here today to share with you some of the findings of our report that was released just this September. In the spirit of how housing matters, the report really begins with the premise that housing is very closely tied to well-being for older adults, and by that we mean older adults over 50. The cost of housing is tied closely to financial security and retirement and the ability to access necessities like food and health care and long-term care. Given the disability rates rise with age, it's tied closely to the physical structure of housing is tied to safety and ability to remain independent. And the location of housing matters as well in terms of your ability to remain engaged in the community, independent, and to access needed services. And finally, what this panel will talk mostly about, I think, is the connections between housing and healthcare. How do we make it possible for people to age comfortably and affordably in their home or community rather than in an institution or in an inadequate situation? So most people state they want to age in their homes and existing communities, but we find several areas for concern related to these four things: cost, accessibility, connection within the community, and home-based care. And that clicker
is right, the clicker?
Yes.
Right next to you.
Thank you. So just to begin with some of the demographic shifts that we're seeing ahead, what are we dealing with? The growing population over 50 is really happening. It began in the 90s with the first wave of the baby boomers reaching age 50. It's continued now. We see that the 65 to 74-year-old age group will nearly double by 2030 to 40 million. And then after that, the leading edge of the baby boomers will continue to expand the population 75 and above. So that group will reach over 30 million by 2040. Right now, 1 in 7 people in the US is 65 or older. By 2030, that will be 1 in 5. And right now, again, 1 in 16 is 75 or over, but by 2040, that will be 1 in 8. The population will be increasingly racially and ethnically diverse, reflecting changes occurring throughout the population. And this has possible implications for multi-generational living arrangements because Asian and Hispanic households are much more likely to live multiple generations together. With age come increasing risks that affect housing needs. In particular, rates of disability rise across the board. While a quarter of older adults have a cognitive, hearing, mobility, or vision difficulty, that's a quarter of people over 50. By 85, 2/3 of adults do. Chronic conditions also rise with age. And we're managing diseases better and people are living longer lives, but the incidence of people living with long-term conditions will rise. Finally, one risk of living alone, that increases from about a quarter of households in their 50s to about three-fifths of households aged 80 and over, and the majority are women. This is a risk, not the only risk for isolation, but one of them. So let me turn now to those 4 challenges I mentioned. Affordability. As people enter retirement, differences in income largely disappear as people stop working, and the median income of those in their 80s is around $25,000 a year. As a result, many households, renters, but also owners, face housing cost burdens and cut back on food, healthcare, transportation, and for that younger group, the 50 to 64-year-olds, on retirement savings. 20 million older adults are currently cost burdens. That's a third of those over 50. A couple of big concerns about housing affordability going forward. First, for the homeowners. Most older adults own their homes. The home ownership rate is in the high 70s to low 80s, depending on the precise group. But more and more people are carrying mortgage debt into their retirement years, which is a concern because they may be less able to use their home equity to access things like long-term care. There's more non-mortgage debt as well, as you can see from this slide. So the housing cost burdens in this slide shows that owners who own free and clear are the best off in terms of their housing affordability, and there's some concerns about those, even those owners who have mortgages. The other thing we're looking at is that we expect more low-income older adults. If you kept the income distribution the same as it is today, and you just project out that population increase, we're going to see a dramatic increase in low-income older adults. And right now, only a third of those 62 and over who qualify for federal assistance receive it. So, I'm sorry, this is the share of the owners with mortgage debt. So not only do more people have mortgage debt, there is more debt and the loans are higher. And this shows the eligibility versus those who are able to access subsidized housing and just the projected need going forward. The second thing that we looked at was accessibility. With rise in age-related disabilities, the need for accessible housing expands with age, and with more older adults, we'll need more accessible housing, yet the current stock is not sufficiently accessible. 90% of those with disabilities live in the community. There's not a huge proportion living in institutions like nursing homes, so the need is right there in the community. We looked at 5 features that you can see on the slide, 5 common measures of universal design, and we found that only 1% of the housing stock has all of these features. 43% of the housing stock has only one or none. So the chance of having a disability is greater than your chance of living in accessible housing. And for lower income older adults, who are more likely to have disabilities to begin with, just a quarter of assisted units have 3 or more of these features. And of the non-subsidized affordable stock, only 550,000 units in the country that rent for $400 or less a month have these features. So a third concern is connectivity. Almost 3/4 of our older adults are aging in suburbs and exurbs and in rural areas that are obviously very car dependent, yet many do not drive or end up limiting their driving. Given that many express a desire to age in their home or community, we need to think about ways to help people avoid isolation in their homes, remain engaged in their communities, and access the services they need. Even in places that have transit accessible, the transit may not be convenient, safe, accessible, or affordable to the older adults who aren't on a commuting schedule, for instance. Walking is a great option, of course, but much needs to be done to improve the pedestrian infrastructure with older adults in mind. And finally, turning to housing and healthcare, We're concerned about how people who need long-term care can obtain it in their home or community in order to avoid or delay a move to a nursing home, which is less desirable to most and more expensive. 70% of those who reach the age of 65 will need long-term care at some point, and there's an estimate that that's 27 million people by year 2050. The care is obviously expensive, as this slide shows, and a median renter could not afford even 2 months of in-home care and less than 1 month in a nursing home should they have to pay out of pocket. Many rely on family, but the future generation will have fewer caregivers to rely upon. There's a desire to age in the home, of course, away from nursing homes, which results in a need to build better bridges between housing and healthcare, which this panel will be discussing shortly. But there's a real lack of affordable and accessible housing that may mean premature moves to an institution or an inability to leave a nursing home after an acute event. So if you go into the hospital and you go to a nursing home and you've left your apartment, it may be very difficult to then move back to something in the community. There are models that include using Medicaid waivers to support care and modifications to homes. There's a program, Money Follows the Person, to help people make that transition out of the nursing home back into the community. But we have some good models and pilots, but obviously more options are needed, and that will involve, as we've been talking about all day here, better coordination among housing and healthcare programs at all levels of government and among the private sector and among property owners and health providers. So these are just touching on some of the issues that we covered in our report, and just to bring home the point that this is something that really affects us all across the country in every community. I just want to show you these final 2 slides. This is 1990. There were 5% of the United States counties had a population where 40% or more of the county population was over age 50. Those are the red dots that you see in this map. This is the last census, which just shows the movement, the incredible aging that is occurring in all places of the country, and just points out the fact that this is something that local governments really need to pay attention to, as well as all of us here today. Thank you.
Great, Jen. Like I said, if you haven't read this report, she just did the 90-second preview of a dense body of data that is so well presented on why we really need to pay attention to what's happening as the country ages. And I mean, my big takeaway from that, more than anything, is that as we age, income disparities are going to be equalized, yes, and that the need for people to have housing-related assistance wherever they live is going to increase in pretty dramatic ways. Absolutely. So thank you so much for that. I'm sure people have a lot of questions, but I want to give Mike an opportunity to talk to you about the great work that he's done in this area.
Great. Well, thank you very much. First, I just want to say it's great to be here. Obviously, I'm in a finance department. I'm not a traditional kind of person who gets to participate in these discussions, and a part of this is just the great work that I've just been doing with my co-authors, Gary Engelhardt from Syracuse University, and then Nadia Greenhalgh-Stanley from Kent State. And what really brought us together was really the opportunity of this MacArthur grant, and particularly what we really looked at 2-3 years ago when we first kind of said, I think we could do something great here. We just wanted to kind of take a look and say, there's a lot of great policies out there. What can we do? What's really the snapshot, and what's really kind of missing in the information? So I just want to say it's great here. Through the MacArthur grant, we really have 2 kind of main, the products. The first was really just a snapshot, kind of a profile as of 2010. How does our older population look? That's the 50 plus, but a particular focus on the 65 plus. And really, in many ways, it complements the Joint Center study. With what we really tried to focus on that was drawing upon great data from the health retirement study, is what's really the functional, just limitations of individuals, and more importantly, where do those individuals live given those functional, those limitations. Kind of the key findings, which I think is also true in the Joint Center report, is we look at older renters and we really see a vulnerable population. 44% of them spend more than 30% of their income on rent, and obviously as they age, we expect that percent to get much higher. And I think that's something just to realize. A part that we did discover was there's still a huge segment of kind of low-income homeowners as well, and especially as that 80% ages, obviously we need to be including them in the policy discussion as well. Not surprisingly though, if we do look at renters again, they have really double the limitations of the homeowners in general. But really, it's again, when we started looking at that kind of 10 million, we started to see kind of some particular of really what could be done for them. As we see, if we just parse out basically a serious fall, roughly 36% of people over the age of 65 had some sort of fall within the last 2 years. When we start looking at serious falls, it's actually much higher. Just in particular, when we start looking at renters versus homeowners, we see renters actually are much worse off, where roughly a third of all homeowners and renters really suffer that fall, and then a third of them have a serious medical treatment. Altogether, they account for about $34 billion in 2014, like the dollars, as far as expenses. So this is a significant chunk of change, particularly when we start looking over the lifetime, right? We see some, more than 50 to 60% of individuals over the age of 50 have had this serious fall. So the question is, what could really be done? And one of the things that we really tried to look at was, what about the presence of safety features? How could we prevent falls in terms of grab bars, shower seats, and really what segment of the population has? I think a lot of older population knows they might fall, so how are they going out there and just preparing? And really we only find about a third have really a safety modification. So I always view that there's the safety modifications to prevent a fall, and then there's accessibility features kind of post-fall. And again, I was thinking, okay, well, it's a third. What do we do there? Obviously we're spending $34 billion a year, and really those modifications cost a couple $100 a piece when we start thinking about it. And one of the things that kind of was our second study was we started to really look at, well, having these components in your house, how do they prevent falls? And one of the things that we came across in literature is, if we just take kind of cross-sectionally, kind of from a correlational sense, having a safety feature actually is correlated with being more likely to fall. Now, most people in this room know that grab bars do not kill, but still, we need to parse out, well, what is the actual effect? And again, that's I think an important kind of how our literature helps, and how just taking a look at really these falls. And what we ended up doing is, from that cross-sectional sense, we really started just looking at the widows, and then using their spouses to just predict what's the probability of your spouse's health really just affecting your probability, since there's this joint decision within the household of just actually having those features as well. So while we find in a correlation sense that grab bars are more likely to actually have a serious fall, once you kind of tease out kind of the causal effect, we're really looking at a 21% decrease of falls of really having kind of one of those 3 or 4 kind of main safety features just within your house. So that effect also increases with age. Just in particular, those over 75, we see probably a 50% reduction in hazards. So working backwards, we then said, okay, well, what would actually happen if we actually invested $1 at the margin? And one of the, I think, most shocking results that we had was we really see for every $1 invested in safety modifications just within the house, where the average, it's the average modifier spends about $1,300, we see between $1.03 and $2.26 just return on investment, or really a return per dollar, for every 2 years in reductions in medical expenses. Now, that's every 2-year effect. That's a pretty large just return. So one of the things that we started thinking about was, well, what could we do? Right? I mean, we have this, so we started talking about some different possibilities, which I really look forward to talking about today, of really what can we do? I mean, I think, again, our results not that surprising, but I think we help provide some concrete evidence that says we could do more. And just particularly, why aren't people really making these modifications themselves? Thank you.
Did you just say, why aren't the people at HUD making these?
The homeowners and renters.
Okay, one of the things I was just thinking about is that I've been in an incredible number of conversations about grab bars recently. I'm glad that you finally set the record straight on the fact that grab bars don't kill. But the thing that's very striking to me is that I think it becomes one of these finger-pointing who should pay exercises.
Absolutely.
And I think the return on investment frame is maybe a more helpful frame. In terms of, instead of, because it's a part of the bricks and sticks that HUD should pay, but the return is over on the health side. Let's just kind of think about it from a bigger sense of this is what's going to make sense in the long run for public expenditures, for community expenditures, and stop having this kind of finger pointing who should pay.
Which is absolutely true. I mean, I think the big thing about that return on investment is that's really an understatement. I mean, we're not taking account of the psychological cost of the fall. I mean, it's really scary when this happens, but I think it's a place to start the conversation, which I think is always important in a policy debate. So, thank you.
Great. Pam, so let's talk about the great work you've done.
Okay. Let's see if I can. Whoop. Already screwed up. So, my job is to tell you about what happens if you say, we really recognize a problem, what are we going to do about it? And so at a local level, we've started very small. Actually, several years ago in Richmond, Virginia, we went forward with trying to do some of this policy type of research, look into databases, looking for some funding and trying to describe the population in the Richmond area. And then after several years, we went, oh heck, why don't we just do this? And lo and behold, when we started very small, it actually caught on. We got a teeny tiny amount of money from our university to go out and pilot a program, and to be very specific about that, it was $16,000 to go out and start to have a program that is clinic-based on site in a low-income housing building. And this was an opportunity for us to develop a model that then could be replicated across the city, hopefully to go backwards in and do what we really wanted, which was take services to older adults that are aging in place. It's been recognized, and we now have our own little logo, as you see. We're the Richmond Health and Wellness Program, and we've received some larger funding, which sounded like a lot of funding to us. It's from HRSA, and it's under HRSA's nursing foundation phase, but it's an interprofessional program that we do. So my job is to describe that program to you. We've partnered, we first went out, and how we did it. So we first went out and we approached one of the housing partners in our community that we thought would be receptive. We're pretty good salesmen and we can pitch something well. So we went to them, they were receptive, they understood, they had a need. We had a need from the university level to try to address this movement back and forth of these low-income older adults that are going to the ER and back and forth to the hospital because of all of the social barriers and the social determinants of health that are affecting their quality of life and how they're aging in place. If we could help to reduce some of those healthcare utilization factors and try to keep people out of nursing homes, then we were going to be doing a positive thing. So Beacon is our local partner, and Dominion Place is the name of the first building that we've gone to, and they were very, very receptive and have been a great community partner for us and have really helped us to start to refine a model and to be able to start to then disseminate across. So we're very thankful to them for doing that for us. As you can see, this is a building that has Section 8 vouchers, and you can look and see for yourself what the income level is and what the population looks like. I want to describe to you very quickly what we do. We take teams of students from, this is an academic community partnership. So we have health service expertise, and they know something about housing. So we have a really nice partnership here. So we take teams of students and licensed faculty members. I'm a nurse practitioner. We have physicians, pharmacists, social work and medicine teams that faculty are on site 1 day per week at the building. And then what we do is through addressing what we know of from our licensing backgrounds in teams, we actually are addressing some of those social determinants that are the reasons for why they're moving back and forth, added on to their chronic illness burden. So we have an understanding from 2 venues. So that's what we do, and one of the key things that we're doing is care coordination. We are not their primary care providers. If they do not have a primary care provider, which sometimes that happens, we've seen people there that haven't had a physician in 12 years, and now they're in their 70s to 80s, and they have very significant health issues. So we hook them up with us or a different provider in the community if they request that, and they can come to our established clinic at our university site. We do counseling and student teams, so this is a great venue for students to be able to come into a site and to learn how people actually live in the community instead of just seeing them, whatever their discipline is, in a hospital bed or in a dental chair or in a mental health clinic, and not being able to get it about what's really going on with that person and why they're having the experiences they are. So that's kind of the approach that we take. We do a lot of triage for medical acute illnesses that come in and a lot of education and counseling. So it's a really unique opportunity for students to be on site at the building, and we are able to provide health care in a sense while we're doing an education component. We're also, from a housing perspective, enhancing the services that are provided on site. This is how our teams look. So we have 3 or 4 rooms of teams going on at the same time with differing faculty members. And we also do something that's also a little unique in that if someone is particularly ill, they've come back from a hospital or an emergency room visit, and they request this service, then we will actually do a house call for them. So my practice experience for long term has been within a geriatrics program at our university where they actually do house calls. So I understand that component. So we can bring an interprofessional team into the home and do comprehensive assessments and help direct them to get that care they need so they don't fall through the cracks when they're coming back with 10 new medicines. Maybe they can't read, they're at fall risk, all of those kind of elements. This is where we are now in year 2 of our program. We started at Dominion Place. We've added mental health with another discipline to our program. That was an identified need from the community side, from Dominion Place and Beacon, and we've now replicated to another housing unit that's under a different auspice. They're actually under the Better Housing Coalition, which is some 202 housing buildings as well as some tax credit buildings in our community. And through our grant funding, after we've replicated and continue to refine our model, in year 3, we will go, our goal is to go into public housing buildings as well. So our goals for outcomes are to decrease ER visits and health utilization. Again, if we can keep people out of the hospital or nursing home placement long term, then we've done a good thing. And we're measuring specific structured outcomes that are clinical and health service, as well as from the community side through our grant funding program. So it's very small, and it's a different way of approaching a problem because everyone is used to looking at it from the perspective of let's get the data, which is the most important piece for affecting policy, but at the same time, we're providing the service and we're able to provide some data in a different fashion to augment and enhance what we get from our policy research.
Great, thank you, Pam. Thanks for that. James, before you start, I just want to do a quick demographic survey. How many people in the room are boomers? Okay, keep your hand up if you tweet. Okay, how many in the room are Gen Xers? Keep your hands up if you tweet. How many in the room are millennials? Keep your hands up if you tweet. Okay, for the tweeters in the room, I think we proved something there. That was very statistically significant. What I want the tweeters to know is that if you have a question, you're going to have a chance to show it to me before anybody's going to have a chance to stand up at the microphone. Just saying, all right? So James, let's talk about this from the perspective of federal policy and where you sit at the Administration on Community Living.
I want to advance that if I can.
You want it to go forward or backwards?
Forward.
You can talk to somebody and somebody also helps.
Okay. So from a federal policy perspective, my belief is there is no way that we will build our way out of the aging demographic. So I think the best strategy is trying to figure out how to keep people, seniors, in their own homes, which is where most want to be, even though a lot fear the social isolation and fear that the debilitating illnesses will progress and they'll be alone and isolated and get in trouble. But in any case, most people want to stay at home. But there's a lot of factors, if I can get to slide 2, risk factors that really prevent people staying in their own home. And I'm just rattling off a couple of them here. The folks that really get in trouble are what we call the 5%ers in the health world. It's the 5% of health consumers who consume over 50% of all health resources. They have a combination of functional limitations and they have multiple chronic conditions. And as you add on functional limitations and chronic conditions, your chance of being at high risk of hospitalizations, nursing home placement, or other kinds of institutional care just rise geometrically. When you look at nursing home admissions, most, as we would expect, come from hospitals, but then about 33% of all nursing home admissions turn into long stays of 60 days or longer. And it's in that period of time that many seniors start to lose their housing. If you look at the Money Follows the Person program, the federal government, which is a very innovative approach to say if a person's been in a nursing home for over 90 days and we get them out, the federal government will pick up the full tab for a full year. But the biggest barrier in every evaluation of that program is people have lost their housing. You have to completely recreate new housing opportunities. And so far, over 5 or 6 years, we've only moved about 30,000 Americans under that program. So the loss of housing in that period, and Congress actually reduced the wait time from 180 days to 90 days to saying you only have to be there 90 days, but even that has not really changed the same pressing need for housing for folks after they've been in an institution for a while. The other area is most of our long-term care system is done by caregivers, family caregivers. 85% of all care to Americans who have functional limitations is done by their own family. Nearly 15 million Americans are involved to some degree in supporting people with dementia. They're just stunning figures. But in many cases, we provide little support. The United Hospital Fund and AARP has put out a couple of incredible reports saying nearly half of those caregivers also work, and nearly half of those caregivers also provide real intensive medical and nursing support tasks, and often with very little support from health professionals. And I have talked to many, many seniors who talk about the hospital discharge process, and literally at the end you're thrown bags of stuff and equipment and given instructions on complex things like open wound care, and you go home and you very quickly get back in trouble. So we put a tremendous burden on family caregivers. And finally, depending on what state you're in, on Medicaid spending, once a senior has spent down and Medicaid finances their long-term care, the discrepancy in performance across the states is really unacceptable. I mean, we have very progressive states at the high end and other states that spend virtually all of their dollars on institutional care and not community care. And then already has been mentioned, there have been some surveys about who's even thinking about doing any housing modifications for when you age, and certainly the 40-year-olds are not, and I think Mikey said even the 60-year-olds are not thinking about any housing strategies. So,
Try the green one.
Try the green one. There we go. So what are the strategies? A couple things, and these are things that are being done all over the country, but the whole issue is really scalability, is how we can begin to scale what we know works to be statewide comprehensive strategies in every state. Obviously, wraparound case management and attention to care transitions, particularly at times of hospitalizations or nursing home placement, is unbelievably important. And we tend to focus all about the hospital readmission penalty, and so a lot of the evidence-based programs are focused around that 30-day window. Well, we know a lot of those folks have a much longer trajectory of needs that really should get intensive case management and support. Support to family caregivers. There are ideal programs in many states that do peer support, that do respite care, and other, train people how to work with someone with dementia. But in most cases, it's not scaled statewide, and it's not a comprehensive strategy. Housing. Since we know many seniors are not in accessible housing, have not prepared for it, Medicaid can be a great fund source to do housing modifications, but there's all the other folks that really no one is focusing on their housing needs. I have been in many seniors' homes where you go in, they recently have been hospitalized, they have a raised toilet seat, they have the grab bars that don't kill, but they have the throw rugs all over the place that do kill. And we don't have a systematic way of trained staff going into those homes, doing an environmental scan, and looking over sort of the progression of the person's aging or multiple chronic conditions, what housing mods will work over time for that person. It often tends to be on an emergency basis. And I've heard Henry Cisneros talk about what if we had something like the weatherization program where we had trained, skilled professionals that could go in and do that kind of support. And finally, conflict-free counseling for people as they face long-term care decisions. We have all kinds of fledgling models called Aging and Disability Resource Centers and called other things, where when you get into trouble, or if your mom is hospitalized across country and at the last minute is told, well, here's 5 nursing homes you can check out, and people get into a complete panic, where can you turn? And we are working at the federal level to develop more models where you'd have an automatic go-to place for conflict-free case management or counseling about what your options are, particularly how to use your private pay resources. And I'm very concerned, you don't have to watch TV very much. The commercial world is really, really focusing on this population and selling, or pitching or advertising their products, many of which are great products. I don't dispute that at all. But really where we need to start is where the person is at, what their family, their community network is like, what their private resources are, and then build a plan from that, not simply refer someone to some pre-existing type of model.
Thanks, James. I love it when our friends at HHS say housing. It's
and you should pay.
It's more, of course. But to wrap all this up, I think that the bottom line that I'm taking from is that James, the federal government, is saying that what Pam is doing in the community is great, and Mike says it makes sense, and Jen is saying we got to do a lot more of it really quickly because this is going in the direction of the boom. So. I'm going to use moderator's prerogative. I want to talk about this in 3 parts. I want to talk about the healthcare side of it, I want to talk about the housing side of it, and I want to talk about the stuff that's in the middle. But because I'm at HUD, let's start with housing. So what are the housing solutions? What are the housing investments? Help me get my head around the magnitude, not only the magnitude, but also the form of what it is that we're talking about. Conversation. I said I wasn't going to do that call on, talk to audience thing. We're going to let's talk.
Well, I think what I tried to say before, we're looking at a real lack of affordable and accessible housing. So that's one thing, and James, you just talked about that. So for people returning out of an institutional spell, finding the housing that is safe and affordable is a real challenge. So there's that. We did sort of back of the envelope assessment about what it would take to make home modifications to some homes. If the average cost of a ramp is something like $2,400, and there are several million people who have an ambulatory disability and live in a house with stairs, and you sort of just back of the envelope that, you're talking a couple $2 billion worth of investment. So there's both a huge need and a huge market. So I think that's a sort of a two-sided thing. There's a lot of opportunity there, but there's also just a huge need. We also talk in the report about other housing options that should people find that their current house is not suitable, We need more options within a community. So we've talked about accessory dwelling units, things that can help somebody stay in the community, but not necessarily in their home, which may be too large, too expensive, not accessible enough. So there's some ideas.
Others want to jump in on that?
Right. I mean, I think the big thing just to draw on is the fact that there is an industry. I mean, we know from individuals that we need this housing, but I think, as we said, $20 billion by some estimates of kind of modifications, winterizations are to be out there. And the question is, why is that industry hasn't really developed itself, right? Why isn't there, somebody knocking on everybody's door and saying, hey, let me improve this modified housing? And I think that was my big takeaway, at least from reading your report, was there's a lot of, there's a reason why I'm in a business school is because I really think there is a potential, both really teamed up with low-income housing tax credits, but also kind of the individual kind of homeowner basis just to provide that, exactly what you're talking of.
You want to throw anything into this on the housing side of it?
Well, on the federal side, we joke about who should pay, but we do have to figure out some better strategies, particularly when people have spent down and are at risk or are actually institutionalized and need housing. The Medicaid program, which does wonderful things for people in supporting them in the community, on the community side doesn't pay for housing. It's completely dependent on a person's SSI payment, which hasn't kept up with anything, and in reality it doesn't pay for the housing costs. And yet on the institutional side of Medicaid, we can throw up buildings and nursing homes, totally capitalize and amortize the costs. So we've got to sort of noodle our way through what's the financing going to be, particularly for people that are poor and getting poorer to support their housing needs.
It's really clear to me that as a society, we have not been investing in the creation of more housing options at the pace at which it's needed across all population groups. The curves on your graphs are stunning in terms of what it says about need and about people's financial situation as they get older, and we're going to get older and we're going to and live longer, and so that is, that's just a fact, I think. But the other thing that's striking to me about all this is that even as we have not invested on the creation of more housing or housing assistance, the healthcare spending trend lines on that are on the mandatory side of the budget, and they will continue to go up and up and up. You talked, Pam, about trying to find the money to do the thing that made common sense to you and just deciding to go forward and do it, anyways. But this question of how do we pay for the things that we need that are going to make sense against the healthcare spending that we're going to inevitably do if we don't? How do you think about that conundrum? Conversation, just talking.
These are deep questions, so it's tough. And
how do you use your role as an economist?
Okay.
And the fact of the return on investment in the grab bar, how do we use that to get more grab bars?
Right. I think the natural connection is going to people just like James. And I think, obviously, what's still the limit of our study is, it's somewhat stylized. We look at, like the widows, and I think then bringing this to scale was so important, exactly what James is talking about. So as we think about how do we do this investment, the natural question to me is, well, how do we identify those people? And more importantly, how do we go out in the community and help motivating those contractors? Is it just simply a tax credit, such as Virginia Livable Home Tax Credit? Is it a subsidized loan program in some cases as well? And I think, I wish there was an easy answer, and I think ultimately that's where we need, I think, more research, honestly, is to figure out, is it, I'm more of an economist, so I always think, that we could tax and subsidize kind of externalities, but I think there's also kind of a behavioral aspect of just educating people or connecting them to the contractors, which I still think is left for really a lot of people in this room to kind of do, so.
And there are some models of municipalities sort of trying to create incentives for new housing or rehabbed housing to have modifications in them through visitability or universal design ordinances. There are these grants and low-interest loan programs that help people do that or help builders do that. There are volunteer programs where people can go into the home, like Rebuilding Together. So there are options, but it just seems like there are great models out there. How do we bring them up to a bigger scale?
Right. Right. I mean, something which I always find is challenging with fall literature is, we really do two ways currently on a national basis. One is maybe you fall or Medicare helps subsidize it after the fact, and it's more accessibility, keeping you in the home. And, I still think sometimes that's almost too late. And then the other way is tax deductions, but really the people that we need out there don't have the disposable income or the taxable income to really think about that. And that's why I think it's important to think outside the box of, I think what's great with the Virginia Livable Home Tax Credit is that, they originally, this was about $5,000 for individuals to modify their homes to do one of the 5 things, and we didn't see people really take it up. So one of the things they did was they went on the supply side and they started talking to the contractors, where contractors now are going out and saying actively, would you like this done? Or more importantly, when they're constructing the properties, they do it as well. And I think stuff like that and really addressing it, I think, ahead of the time before it becomes the long-term care type situation is, I think, key.
Did you want
Well, no, I was going to say, I think, we have embarked, or we're well down the road on this big noble experience of moving lots of these populations into managed care, and sort of on the heels of Medicare Advantage. And I think over time, the big managed care companies, including the commercial world and the nonprofit world, will figure out, and I think some are already, that housing is a healthcare cost. That healthcare is done least well in clinics and hospitals, but done best in community settings and in people's own homes. And you already see some hospitals